Okay, it's 8 p.m. here, so I think it's a good time to start. Dear UEP members, dear friends, it's my honor to be with you today to welcome you to the UEP Swallowing Committee Virtual Forum webinar. Actually, this will be the first of a series of events we hope. And I would like to thank to the Swallowing Committee chairs, Professor Daniele Farnetti and Professor Mohammed Farad for this initiative. And of course, I would like to thank the panelists and moderators of this meeting for making this possible for all of us. And I want to leave the stage to Dr. Mariam Shadi and Dr. Sally Adel, the moderators of tonight. I hope you will enjoy it. Thank you very much for being with us.
Thank you, Haldun, for the welcoming words. Now let's proceed with the webinar. First, we would like to introduce our esteemed speakers. Sally, please. Sally, you're muted.
Hello, sorry for the delay. First of all, I'd like to introduce our valuable speakers. The first speaker is Professor Dr. Virginie, after having created the voice and the deglutition unit in the Department of Otorhinolaryngology and Head and Neck at the University Hospital of Toulouse in 1992. Professor Wizard opened 2 units in the Cancer University Institute of Toulouse in 2014, the Onco-Rehabilitation Unit and the Intensive Rehabilitation Unit for laryngectomized patients. At that time, she works in these 3 units and leads the University Training Center for Leucopedics of Toulouse. Dr. Daniele Farnetti, our first professor for the discussion, is an otorhinolaryngologist, phoniatrician with over 30 years of clinical practice and research experience in swallowing dysphagia and instrumental assessment, including both PEES and video fluoroscopy. He's a contract teacher at the University of Bologna, Ferrara, and Parma. He was a founder of the European Society for Swallowing Disorders and the board member until 2021. He's currently the chief of the Audiologic Phoniatric Service at the Rimini's Hospital. And last but not least, Dr. Varen, Doctor of Rehabilitation and Chest Medicine at the University of Rouen. He is established a dedicated for swallowing individuals with multiple disabilities. He's also a board member of the European Society of Swallowing Disorders. Dr. Varen chaired the 38th Congress of the French Physical and Rehabilitation Medicine in Le Havre, France in 2023. He encompasses not only dysphagia and pulmonary disorders, but also peripheral nerve stimulation, brain plasticity, consciousness, and psychology. Thank you.
Welcome, everyone. And as Dr. Virginie progresses through the clinical case, I encourage you participants to submit your questions in the chat box. She will pause at 5 key stops along the presentation, marking the follow-up periods to invite our guests for discussion and address your questions at these allocated intervals. So without wasting further time, Virginie, the floor is yours.
Thank you very much. So I will share the presentation. And just at the beginning to say that we propose to have a clinical case with a long story, and so it's possible to analyze the several steps of the management of the patient. That's why we asked to you to have some questions during the presentation and not only at the end. So I will attach. So it's okay for the screen? You have a good,
yes.
So thank you.
Yes.
Okay, so the case, because we have few times. The story of this man begin for the medical aspect in 2000, I don't, at this time. I have a matter with the dates. So it's a male, it's 65 years old, he's retired now. At the beginning of the story, the syndrome was a cerebral one, and that's motivate a consultation with a neurologist, and the diagnosis of the disease was an ependymoma of the left pontocerebral angle. So he was treated by surgery twice in these dates, and he had a radiotherapy for controlling the disease. At this time, the approach was a surgical approach, posterior one, by this way, and he has a peg just before the treatment, and after the second surgery, he stayed 1 month in the ECU with a secular severe dysphagia. After only 3 months in a global rehabilitation center, he was able to come back to home, but he keeps severe difficulty with saliva and poor cough reflex. That's why during this period, nobody tried to test the swallow with him. So the sequelae are a left facial, lingual, velar, pharyngeal, laryngeal paralysis with a mild cerebellar syndrome and a left deafness. When he arrived in Toulouse, it was at this date, and we performed the first assessment. The other medical history are not impacting really the story. He is very fatigable, but he's autonomous and very volunteer. And so for the daily activities, there is no limitation, and he has no cognitive matter. He has a nursing visit per day for the enteral nutrition. As treatment, he has omeprazole for the reflux and scopolamine for the saliva matter. And the motivation to consult is really the saliva, because he is always it's necessary for him always to spit, and he hoped to eat again some food by mouth because he didn't eat since 2 years. There is no pulmonary since 1 year. Physiotherapy for bronchial congestion and facial paralysis is performed regularly. He has no swallowing or speech rehabilitation since 1 year. The weight is too low comparing with the situation before the treatment. It's limit for the nutritional status, and it has no thing. All the food is enteral by the peg and nothing by the mouth. So when we examine, we perform the examination, you have see the mouse with you can see the velum paralysis. You can observe also the facial by the difficulties of the mouth, asymmetrical opening of the mouth, and you can see also there is no important deviation of the tongue, but there is a less strength on the tongue. Before the test, the surprise and not so surprised is the importance of the saliva in the throat. When he spit, it's able to limit this residue of saliva, but it's very, very important. If we look at how he speech, you can observe an asymmetry called dynamic in the larynx and in the pharyngeal wall. It's not a full paralysis, but there is an asymmetric situation. And when you try to swallow, it's long, very long, and you can see the residue there. And it's not so bad, surprising when we compare with the saliva situation. But if we... So you can see at the end of the test with 1 cc of yogurt, and it's a small amount, but it's not so bad. But if you look at the situation, if you wait a little bit, but you can find this situation with, again, saliva and overflow of the residue with the saliva. If we complete the examination by the VFS examination, always on the small quantity of yogurt, similar of yogurt, it's a barium. You have first difficulties to have a pharyngeal transit, and when you observe that, it's possible to have a passage by teeth by the left part, and an overflow by the residue there. If you use a posture to see what happens in the right side, it's well working, and it's better with less aspiration. And if you need to show. If you try again in the neutral position, it's with the liquid, it's difficult, very difficult. And so 20 minutes after we perform the VFS, you can see that there is a lot of residue and some aspiration, very important aspiration. For my colleagues, do you have some question, or what is your impression for this patient? The severity you imagine, and the management you can propose.
Virginie?
Yes.
Can I answer? Before answering you, can I add something about the swallowing committee? Mariam and Sally, could you give me this possibility?
Certainly. Yes. Go ahead.
Thank you so much.
No sound. We have no sound. Daniel.
Sorry. Yeah. I muted. Sorry. Thank you. I was saying that after all, good afternoon to everybody. And I've had the pleasure of coordinating the swallowing committee since 2016, and for 3 years I have been supported by Mohamed Farhat as co-chair. The swallowing committee brings together the activity of several professionals spread throughout the world. Over the years, we have published articles, managed the swallowing part of UEP congresses, and organized the activity of the World Swallowing Day, started by Professor Mohamed Farhat. Within the committee, a group of professionals deal with dysphagia in the pediatric age. The Pediatric Swallowing Committee is organizing a survey in this sense. The survey will also be available on the UEP website shortly. Today is the first virtual forum. Another is planned for the 30th of October. The virtual forums are meetings designed to compare the experience of a professional expert in the field for the benefit of younger colleagues, providing ideas for diagnosing and therapeutic management of patients with dysphagia of different etiology. I invite you to consult our space on the UEP website and consult the UEP newsletter and social media to follow our initiatives. Thank you for that, Sally and Mariam. And now to respond to our request, Virginie. Your case seems very, very complicated and very difficult to approach and to solve. And luckily, you show a long time for the follow-up. So it's a long story. It seems a very, very complicated situation because the patient has 2 years of no use of non-use in the swallowing, and it's a patients malnourished, so very, very thin, very, very fatigable. His only lack is that he is very motivated. So is compliance, or I'm expecting it will be compliant to the therapeutic plan, every therapeutic plan that we have proposed to him. Of course, the quality of life of the patient is a matter, is a concern, because he is very, very proved by his pathologies. The sticky saliva is extremely discomfort for him. And I'm confident that he was looking for every possibility to reduce saliva, saliva sticking in the mouth. As you have shown us, there is a complicated situation about the cranial nerve working in the area. So the left cranial nerves are not working, and the facial one. And there is a not coordinating valves activities. Another concern is the not well working upper esophageal sphincter. So there are several conditions that you have to take in consideration during the treatment plan or the proposal for the patients. So the first consideration is the management of this saliva and to improve the sphincterial activities and coordination of the valves during the upper aeroesophageal tract. It is my first consideration. So sensory stimulation is also another important issue.
And Eric, do you want to add something or to make a comment later?
No specific comment about the first part of this presentation, because as said Daniele, it is quite complicated patient, and my question is there before pneumonia, because you say about 1 year, you say yes that you follow the history for 1 year. But before, does this patient had some re-education? And which sort of re-education? Physiotherapist, speech language therapist, and so on?
Oh, he have a global rehabilitation in a global center. And so they don't work, they work during the 1 year on physiotherapy for the lungs, and they work a little bit in speech therapy, but without any swallowing tests. So when he arrived, he stopped in all this kind of re-education, perhaps 6 months before they stop. There's no specific rehabilitation of the functionality of our digestive tract. Only they work on the facial matter because they give up.
Okay.
They give up.
So
what
there are no questions on the chat, so we can move forward with the case presentation.
Alors, why it's not working? Sorry, but I have a matter for going ahead. Ça y est. So our contribution and course action was to that there is the difficulty. I totally agree with Daniele of the fact of the lack of coordination and the lack of coordination between the several structures. But we focus on the loss of strength, mainly on the tongue and the pharynx, and that can be controlled by posture and maneuver, and some difficulties to trigger the pharyngeal phase. It may be a difficulty to trigger or a difficulty of coordination. It's very difficult to analyze that precisely. But what is important for us is that it's most important and crucial for automatic or second swallow. The voluntary gesture is better. Voilà. It's an observation. And it's why we seem that the prognosis does not seem good, but without any specific trainings these 2 years, we propose to try some stimulation and to follow the evolution of the rehabilitation. And so the rehabilitation was focused on analytic exercise for strengthening the sensory motricity, particularly the tongue and the pharynx, functional exercises of, for example, oral control exercise, laryngeal evaluation for improving coordination, posture and maneuver training in the left rotation, chin tuck, and supraglottic maneuver. And we authorize inside the training session to stimulate the patient by feeding, by swallowing some food, only 1 cc in the texture of HC2. It's what we propose. And so The second assessment, there is some assessment between, but I focus on the second assessment of this second assessment, that the patient was happy to be able to swallow something, and he was less spitting, but it was necessary to take the posture for that. And so for swallowing the saliva in the posture always, it's not possible. Is less fatigable, is better in terms of nutrition, as you can see there. The evolution global is good. The therapy is performed at home, but a little bit intensive. And there is no change in the enteral feeding, and the oral feeding is the equivalent of 1 yogurt per day only. That's the result we have at that time. And so we assess him again. And before the test, you can see that there is less saliva in the throat. That's the main interesting observation there. You can see really the deficit of the laryngeal motion, not closure, motion, and the pharyngeal paralysis. When we tried 3 cc of yogurt with the posture, there is a long time for having to see, the time of swallowing is long compared to the normal. There is some residue, but there is no aspiration at each time. If we increase, so that is the second time of 3 cc of yogurt, you have more residue, but again, it's not so bad. And you had before the third one, and after the third one, at the end, it can split. With the saliva, we have the same matter. If we wait, the saliva is coming, and there is some difficulties, but it is able to split and to make an evacuation of the residue. And it's with the liquids, and liquids, it's terrible. So it's always there is some direct aspiration and some overflow of the residue. It's bad with liquids and other texture. So we control by the VFS. The first swallow in the profile of ETD was in the posture and so on. It's good. No aspiration, a few residue. Confirm that it's a confirmation of the previous exam. And if we look at without posture, we have a matter with triggering or opening of the US. I know the terms are difficult to define. And if we look at the posture, it's easier. So it's better. And so what is your proposal? Your interpretation, your proposal. Voilà. Again, if there is some question in the chat after, but if you have some comments or some suggestion.
There are no comments from the audience, Maria?
Nothing from the chat.
No,
Yes.
not from the chat. Okay. Can I say something, Virginie?
I
was
we
making
are
some.
here for that.
Thank you. I was making some considerations about your fantastic clips, and the first consideration about the fees clips is a consideration about the residue you made before. Yes, we have a residue, but we also we saw penetration inside the vestibule. Okay, not deep penetration visible in fees, but surely penetration. And you mentioned the second swallowing act, and the penetration increased during the second or subsequent swallowing act. It's a matter because we know that the presence of a residue in the vestibule over the time puts the patient in a higher risk of aspiration, so we can expecting aspiration in this patient, but it is obvious. The other consideration, considering the second movie, the movie in the center, is that after the first swallow, the residue increases strongly in the retrocricoideal space. So it's a matter to have a look to the upper esophageal sphincter. It's true that there is a latency in the activation of the pharynx. It's true, but a matter is probably also there. Sensation, yes, is active, but not so active because the patient aspirates also in the video fluoro sequences you shows us. And in the video fluoro, without the disturbance of the endoscope, maybe there is really a delay in the pharyngeal activation, a long time of activation. And nonetheless, the patient aspirate. And if I remember well, it's an anterior aspiration, so in the anterior part of anterior tracheal wall. So it means that there is a lack of a closure of the larynx in this case. These are main consideration about observing the movie. So the proposal to solve this consideration that you mentioned before, activation of sensation to increase, to activate the pharynx shortly or in a more brisk way, and to coordinate the closure of the larynx to preserve the lungs from aspiration.
For your last suggestion, how do you how is it possible specifically to improve the coordination of the closure?
Oh, but
your experience
with a speech therapist approach, of course.
Okay.
No. Okay, the patient needs absolutely all the speech therapist that you prescribe. And in this sense, I have a question for you. Can I make you a question? Or it's not convenient? I have a curiosity, honestly. You propose to the patient 2 or 3 sessions of speech therapy per day. So the patient is an outpatient.
No, for it's a mistake at that time. It's per week.
Per week.
Per
Okay,
week.
okay.
I don't know if it's a mistake of my.
It's reasonable. It's
per
reasonable.
week.
Okay.
You know that the change in France is that we have a speech language pathologist session reimbursed with a long time of management possible. It's not the same in Italy. It's not the same in Spain, I know, and that's a chance we have. And in the city, not at the hospital. It's possible for us. Eric, do you want to add something?
Oh.
Thank you, Daniele, for those comments, and I'm totally agree. But few questions, in fact, because we have saw that saliva in the pharynx at the first nasal endoscopy decreased, and my first question about that is that do you make something on the saliva glands, for example, botulinum toxin, or do you think that it is only with re-education and rehabilitation that saliva swallow were better? Secondly, for the US, do you think that this is a lack of strength of contraction that decrease the opening of the US, or do you think that this is nervous complication of lack of US opening? And finally, do you think that after this year, the patient is able to eat something by mouth alone without any speech language therapies? Do you think that it is too dangerous, for example, to take yogurt or compote at home for him?
For the saliva, no, we don't perform toxin botulinum injection or other things. He has some scopolamine always, scopoderm on the skin for limiting that. And the evolution is more.
Virginie, I ask the question because I have a lot of complication with botulinum, with scopoderm, scopolamine, and do you think that it is dangerous for the patient to?
It can be dangerous for the patient, but this patient very well support. It's comfortable with that. He have no matter, and we know that some patients have some difficulties and some vertige, some some people it's not possible to keep them with that. It's dangerous sometimes for that. But for him, it was not the situation. He was very comfortable with scopolamine. And for your question about the US, I don't know, because for me, it's always a mystery. I don't know, really, because it's an ependyma of the cerebellum. And so we don't know really what happens in this area. We don't know the consequence of the dysregulation at the neurological pathway. And so we don't know the impact on the left, on the right. So it's not only a peripheral matter. It's also, so we don't know. And there is paradoxal things. At the first swallow we explore, the passage in neutral position was by the left pharyngeal side. And we use the other side for be efficient in swallow. So it's very complicated, sure, because it's not only a peripheral situation, there is always a component of the central peripheral, the brainstem reorganization or compensation. It's very complicated. So I don't know really why the US is not functioning. Is it because the pharyngeal wall is not coordinate with I don't know. So it's an observation, and we can make some hypotheses, but I have no answers to that. And
can I add a comment?
If Mariam, that
Mariam.
is a timer.
Yes, we need to move forward, but a quick comment for Daniele is okay.
No, I would like to underline what has already said Virginie now, because considering I have in mind the sequences of FIS and video fluoro, and there is really a bizarre behavior of the UES, or the upper esophageal sphincter, with different behavior. Sometimes it doesn't open, or sometimes it is open later, or not regularly.
No, sure.
Thank
you. And for the last question, I am an optimist woman. So I always hope that my patient will be better. And so I stop to go ahead when really I am at the limit of the risk. So it's why I don't stop. So it's difficult to me to stop. And so I am optimistic.
Okay, and I have a question for you and Daniele, because it's very interesting for the US. And are you agree that at this stage we can do something on the US, for example, surgery or botulinum injection? Or do you think that we have no proof, so don't do anything?
Well, for these cases, sure,
yes,
I think that we need to make something at the US, but I can go ahead for that. But my interpretation is that there is interesting progression, but no swallowing if no posture, and always more difficulty with liquid and saliva. And the fact that we have more regarding this constatation, for me, there was two possibilities, but the first one I chose for the patient was to recreate the feeling if they can improve swallowing by triggering, and to improve the triggering first before to go to the US relaxation or voilà. And what it was the choice. And so it's why we continue the physiotherapy and the speech language pathology, the reeducation, but we had neuromuscular electrical stimulation at a sensitive level. It's not proved too. So action of the US or neurostimulation as a sensitive level, there is no proof of efficiency if in this indication. But how to improve the speech, the swallowing reeducation without any things. So it's why we propose that. So we arrive at next year. So the third assessment, the patient feels an important, very important improvement. He eats more, equivalent of 1 meal without using systematically a head posture. He wishes to eat more and feel that it's possible. So I want to believe him, but to control before. He tried liquids despite our recommendation. So always he was fine about the pulmonary situation. He don't need more physiotherapist time. He continued to have the logopedics, but less, a little bit less. For feeding, he eats something with her wife at each meal time. And so it's equivalent of 1 meal per day. It's not no more, but it's enough. And the weight is stable. And so if we look at the video, we have less saliva again, but it's and when you swallow, it's quicker. No? We have no the long time we have before. He is splitting, but I asked to him why, and he said because you. I translate the answers of the patient. Why do I say? Why do you make that? And so he say it's because you train me to do that systematically, so I do that. I'm not sure that in reality when he hit with a rifle he do that, but it's the answers of what he performed that. And so here you have the situation after the test, so it's acceptable in terms of residue, and we try liquid. It's a little bit better, but he cough. So we don't see so much things, but and so again, it's better. So up for the VFS in posture. So it's slow for the transit, but the triggering, it's quicker. The second one, it's reproducible. It's and this one more liquid. So the last one is with liquid. Okay. So do you have some comments, some questions?
The microphone. Lot of questions, Virginie. First of all, which sort of neuromuscular electric stimulation do you make? Do you use pharyngeal electrode, surface electrode? Where do you put the electrodes? And second, I saw that the patient had physiotherapy, and do you think that the physiotherapy is able to prevent pneumonia, for example? Because I think that he made a lot of aspiration on penetration. So do you think that physiotherapist has an indication in aspiration to prevent pneumonia. And lastly, how do you explain the increase of the weight? Do you think that because the patient take more by mouth, or do you change the nutritional status with gastrostomy?
Virginie, before your answer, another complementary answer questions. The patient underwent also a respiratory physiotherapy or only physiotherapy?
Alors, for the stimulation, that it's similar to TENS, so we don't use a special device, but only the system used and available in our department in hospital for the pain. And so they begin with stimulation on the ear, on the floor of the mouth, and after that they put some electrodes along the paralaryngeal position. That's what they perform.
Yes, just a comment on that, Virginie, because we do that in a Rouen University Hospital also with very cheap equipment, and that's working very well. And nothing to buy because the equipment is very common and everybody could have it very, very cheaply.
And so, what the question? You're right, but because I deal since long time with ENT patient, we observe a lot of well tolerance of small aspiration in some population. So for this patient, he stay with one session per week of physiotherapy for respiratory matter. It didn't increase the needs of the session of physiotherapy didn't increase, and for me it's that I think that the swallow is better. The amount of saliva inhaled by the patient is decreasing, and I think that it's why is better. The general status is better, and that the weight was increasing at the beginning. At that time, we are stable, but I think that the difference was because the inhalation was less. It's my interpretation. Perhaps you can be not agree, but
I agree with you, Virginie, if I can, because there is less saliva, and the compliance of the general health or status of the patient is surely improved, the weight improved. And also in this last sequence of clips you showed us, in fees, for example, there is a deep penetration. So the patient surely aspirates, not only because video fluoro has showed as aspiration, but over a meal, it is obvious that the patient had micro or medium aspiration because in need every time for every swallow to improve the closure of the larynx is necessary for him to coordinate and to increase the strength of the larynx as a valve. So it's mandatory because he has a deep penetration. And the posture, yes, it's difficult to eat, not possible to go to the restaurant eating in a safe position, for example. So the quality of life is, in any case, reduced for the patient since now. And I think that also the consideration made by Eric are true and conceivable, but I need that there is a margin of activities for physiotherapy and speech therapy in this way. in this stage.
So, so our conclusion was, there is a question?
No, nothing for now. And I encourage the participants to put their questions. These sessions are meant to be interactive. So we're looking forward to see to your participation and interaction.
So our conclusion was that there is a good evolution, but limitation for liquids and thicker food. Our hypothesis is that to try to improve the balance between pharyngeal strength and US resistance. In the progress, we have no more idea. We can have, we propose a botulinum toxin injection in the US in the left part under UMG control. So better nutritional situation globally because he can with all solid food by mouth. And the enteral feeding is only used for liquid. He go faster than we expected. So always stable, no pneumonia, always the physiotherapy, and the speech language pathologists decrease our action. He was only on supervision with exercises performed daily. Eat with her wife. Now enteral feeding for food, 0, only liquids and medication. And for oral feeding is between each 1 and 5. But the main calorie is on each 2, 3. So he makes some experiments. And so we have for this video we have more saliva on the pharyngeal wall, but the swallow. Sorry, I go too quickly. So you have some not so clean, and for the liquid, it's always complicated. But we try a cake, and the cake between when we try the cake is the same situation than for ET2. So I show you again because it's quick. You have some cake there, but he tried to swallow and he can swallow the piece of cake. That's the new things. And reorganize VFS, the new thing is that it's able to swallow without posture. So it's always more efficient in using the left posture. And but if we try more consistent, more solid food, more solid, it's difficult for him, but he able to swallow without aspiration in neutral position. That is the benefit of the injection of US. So same scenario. Do you have some more?
For now.
Can I make some consideration about the clips in waiting for questions from the audience?
We do have some question now.
There is a question?
Rosa is asking, is these cases in the esophageal gastric reflux was investigated with gastric endoscopy and with treatment for the reflux?
So we perform always, when we perform the VFS, systematically we perform an esophageal assessment at transit. So we didn't ask to a gastroenterologist because he has some reflux and he's treated for that. But when we observe the esophagogram, we have no, it's slow, but there is no reflux, mechanical reflux. So it's why always before to inject some botulinum toxin, we verify systematically how is working the esophagus, because the risk is to have a complication by inhalation of gastric content and to worse seriously the situation of the patient. So it's why we perform this evaluation system. I don't say that, but it's systematic.
Okay, thanks Virginie and Eugenia for the question. Moving forward.
Yes, Virginie, how do you explain that the swallow of saliva was worse? And do you think that he is a lucky guy because he no pneumonia actually, eating a lot by mouth, and from 1 year is really at risk, in fact?
For me, the matter is now. What I feel at the beginning, for me, it's a little bit confirmed. The main matter he has is not with swallowing voluntarily. The main matter he has is to swallow automatically some saliva or others. And it's not because he's eating that is at risk. He is at risk because of the situation of automatic swallow. And so we have no solution. I have no idea for that. And the risk for eating is not, for me, the important risk. And to increase the capacity to swallow voluntarily, I hope that it can increase a little bit the performance of the automatic swallow. But for me, the matter is more in the brain, with the capacity to have a reflexive swallow regarding the endogenous secretion of the body. And so it's why for me, for eating for him, it's not so dangerous. Voilà. It's not voilà. It's my interpretation, and it's why I continue to try to help him.
Okay. Eugenia is also sorry, Danielle.
Sorry, there is another question.
Yes, there's another question from
the audience.
Yes, she's asking if you have some comments about the relationship with colitis or slow digestive system with this case.
Sorry, I don't understand the question.
Is this patient's condition related somewhat to colitis or other digestive system problems?
Colitis?
Inflammation of the colon. Is this what I understood from the question? Correct me if I'm wrong.
For me, I don't see the relationship, but perhaps Daniele or Eric have a...
Oh, I don't see the relationship.
No, the motility of the gross bowel, maybe. But it's a strange consideration for me. I can understand or conceive the activities of the gastric bowel or the duodenum, for example, but not the colon, for example.
I think she means inflammation, like inflammatory bowel syndromes or something.
Exactly.
Yes.
I don't know, honestly.
But the question is interesting if we are regarding the digestive tract. And do you think that there was a vagus nerve dysfunction? And if yes, is the patient could have gastric, slow gastric moving or slow colon moving? And
yes, do you think that the idea is that we know that is digestive tract dysfunctioning in link with the cerebral matter, and to imagine that to increase all the system,
The motility.
The motility of that is a good idea. I didn't have enough interest of the whole process of his digestive tract, right? It's an idea for the future management of the patient.
Yeah, she adds that in some of her dysphagia patients, she usually tests all of the digestive movement.
Yeah, but she's right. She's right, and it's a good idea. I thank this person to awake my consciousness to that.
Okay.
Okay.
I
So
don't
moving
know
forward.
if we have no time for other consideration, Mariam. Do we have?
No more questions for now. We can move forward.
So our conclusion was the good evolution, but there is some risks, sure. I'm aware of that. And we propose to control the situation for taking the patient in our intensive rehabilitation center. That it's a very intensive stay with some session of, but the most important of the session is that we have each day an observation with an occupational therapist of the meal at noon. And it was a manner to be sure that he performed well the strategy for eating and to control that he have not wet voice systematically after the meal time and so on. And so I go faster because we have a very good outcome of that. We have a consolidation of the situation without any complication. We decrease the follow-up at that time, but we asked to him to have a control regularly of the fever curve. So to take the fever each night during 1 week each month to be sure that there is no infection. To control the weight and to have a blood test each month to verify if there is no infection, sign of infection. But the patient come back and say that the main complaint he have is the sick saliva, always need to spit, and that is the main discomfort, and he's not able to drink. And so the situation is globally stable. He has no food by the peg. He keeps the peg for the liquids and the medication, and we try what we can do. So the situation is quickly just to show you that the motion is the same. We have always the paradoxal observation that there is liquid residue, but there is no residue of thicker food. And so what we perform quickly is that we try in EC0 with VFS because it's better to see the aspiration in this situation. And so we see that we can have in neutral posture first swallow good, and after you have the overflow that will arrive. Here you see that it's not of the first swallow, it's the residue. It's always a matter. If we use the posture, it's not very visible, but there is no aspiration and after. It's what you see there. And so we attest that probably with 1 cc of liquid, it's possible to drink a few amount of liquids. And we try to, after that, increase the quantity. And we have some aspiration at 5 systematically. And so we propose to stay between 2 and 3 cc and to use that to perhaps helps to avoid to have to try to facilitate the evacuation of the saliva. That's whole. And we are at that time, and we have no more idea to help this man. I don't know if you have some idea to propose. I register the digestive tract in the whole aspect to analyze, but I don't know if my colleagues have some idea to improve the situation again.
Virginie, just a question at the end of the of the re-education. Do you have at the exams cranial nerves dysfunction, for example, the 7th, the 5th, the 10th, or the 9th? do they still did not work, in fact? Is there any recuperation? And do you think that in this case you can, second question, do you think that to improve the patient, it is possible to use more complicated stimulation like magnetic stimulation or something else?
Regarding the cranial nerve, they recover partially. It's like a few paresis. As you see, the larynx is working. There is a decreased motility, but not a total. At the same of the pharynx, sometimes we don't know really if it's the left or the right. So he recover. That's I don't think that we can do more, but I'm not sure. And regarding the question about brain stimulation, sure, I think that it will be a good help. I don't know technically how it will be possible. It was an ependymoma on the cerebellum. I don't know if it's possible really, but why not?
Yes, why not? Yes.
To resynchronize, I don't know, but why not?
Okay.
Daniele, some question?
No question. I was making a consideration because considering the clips, sorry, I'm annoying you with the clips, but considering the clip, it seems that FIS and video floor, it seems that the situation is stable since 2022. So there are no substantial change in the patient. So I think that the patient has reached, or it seems, in my opinion, that the patient has reached his stable condition with the conventional therapeutic approach. And the fact that he has not developed pneumonia because he's aspirating without any problem is that maybe that the lung is a possibility to clear in itself by secretions. That is normal aspiration of saliva. You mentioned that the ENT patient, it's normal for ENT patients aspiration, micro aspiration, and so the patient in this case has the possibility to clear, or the lung has the possibility to clear itself from secretion. What did you do, and what are you doing is fantastic for your patient, and you reach, in my opinion, very, very good, fantastic results. Congratulations.
Oh, it's true. It's a patient, because in some cases we cannot go ahead with the patient, and we need to stop all food and to put not a gastrostomy but a jejunostomy to avoid to have the inhalation of secretion secretion from the gastric tube, because the patient don't tolerate any aspiration. So it's really because this patient have a very good capacity of clear the lungs, that it's possible to work with him. And if not, you know that there is one infection, two infection, and you stop. That's not possible. But it's a patient condition, and we don't know how to improve the capacity to the patient to clear their lungs or to have the immunity to protect their lungs by themselves. But it's my main message at the end is that this kind of patient, when we begin the story, I think that all of us, we say, oh, it's not possible. We can do nothing. It's 2 years ago, so much saliva. My message is no, it's very dangerous to think that we need to separate in our brain the matter of automatic swallowing and voluntary swallowing. And we need to always try to improve by re-education and to see what happens. And sometimes we can have some cues that it will be better, and we can go ahead with the patient with several approach And I think it's the main message is that. And
Yes.
I have just a question for you, because nobody speak about to improve the laryngeal closure by surgery. I'm happy to that, sincerely. But there is no question about that, so it's surprising. But I'm very happy because I don't propose to improve the laryngeal closure, because the glottal
There
closure
is a
was good.
competence in the glottal.
And so it was not an indication to do that,
Exactly.
Yes.
despite the voice.
And
I agree.
Virginie, I think that the main message is also that it could be very long in case of brainstem etiology, because you see it's 3 or 4 years. As we must do that for those patients, because we know that plasticity in the brainstem exists, but it could be very, very long, in fact.
It's new apprentissage, so it's 2 years.
Yeah.
Minimum. If you learn again, it's 2 years.
Yeah.
So it's voilà. Okay, so we have a couple or actually 3 questions now in the chat. Nasreen is asking if specific exercises are recommended for this patient, and what are the precautions you recommend during feeding?
I said that my colleague can answer to me. Regarding the exercise, it's very difficult, but we use a lot of exercise to improve the strength. It's Masakro because he has the ability to do that. It's laryngeal evaluation, it's tongue exercises, most in posterior part to increase the pharyngeal weight, strength. So for that, we focus on that. And regarding the coordination is the exercise with the maneuver as food exercise. It's why we introduce so early the authorization to try with 1 cc. It's to be able to work with the patient in the situation of swallowing for training the coordination.
So you agree that swallowing is the best exercise for the
Yeah,
mechanism
for coordination and work without any.
Yeah.
It's why it's perhaps so long for him, because he don't try really to swallow during 1 year after the surgery. No training.
And are there any precautions for him during meals?
It's always to clear the throat, and because we know that supraglottic maneuver is a good way to learn. It's not a good way to practice during the meal. What it's important is to have a closure, a previous closure to prevent aspiration in the lungs and to have only penetration, and to clear the throat regularly. And for him, it was to, when he eat, he take a neutral posture during 2 bolus injection. And so be careful for him we ask to him to systematically swallow again saliva for the residue in the posture. And we try to limit the risk like that. It's long for him. It's always not natural to eat. It's always something he needs to control.
Okay, thank you.
I don't know if my colleagues will add something. No.
No.
You said it all. Okay.
You was very clear.
Yes,
Okay,
it was very, very nice presentation. Thank you.
Thank you.
Okay.
Okay, we have
Ellie?
one final question regarding Mendelssohn maneuver. If you think, Virginie, it will decrease the piriform residue?
I believe that it's possible, and we try all what we can try in reality. Okay, So to improve the elevation of the larynx, and to it can be tried. So I try everything.
Okay.
So yes, it's a possibility, and we need to try to see that it's working.
Yeah.
Okay. We have a final suggestion from Rosa saying that cervical colon and dysphagia will be interesting. Maybe she means for further virtual forums. I would like to thank you, Virginie, for this enthusiastic and optimistic presentation. Actually, you inspired us all. I would like also to thank all the professors who joined in the discussion, Dr. Daniele, Dr. Eric. Thank you.
Thank you to all.
Okay, and we kindly ask you to take a few moments, dear participants, to complete the feedback survey that will be sent to you via email shortly. We need to know your thoughts and suggestions to improve our future webinars. And speaking of future webinars, we're announcing the next one. Would you please, Virginie, stop sharing your screen?
Yes, sorry.
Okay, can do.
Yes.
No problem.
That's great.
Yes. Okay, here we go. And we're just announcing our next webinar, which will be, can you see my screen? Okay, it will be next October, and we'll have our dear friend and colleague, Dr. Miroslav Tedlev from Bratislava, Slovakia. So mark your calendars. I'm looking forward to see you all there. And I think this is all. We come to the end of the webinar. Thank you, everyone. Bye-bye.
Bye.
Thank you. Bye-bye. Thank you very
Bye-bye.
Thank you so much.
Bye.